Great singer because there's just a bit, I knew the politics and everything. So he was saying, when I go to Rhode Island, I happen to get on the room, album on GBP goes, discusses it freely. 5 minutes later, I come back there because I went up to see one thing. Right down there going to the bridge. Bridge is there, and another person who's doing cycling out. So your hospital is speaking very frequently. You just did recently.
No, I'm about to. I'm sort of getting out the new behaviors that I never did before. I think I'm fine now.
You are?
It's probably fine now.
Okay, all right.
No, no idea where intention is going on. Okay, good, just bring them on in and we'll
Okay.
take pictures of
So
you.
you're all set?
We're all
Yeah,
set?
we're all set.
All right.
Let you do your thing.
Okay,
Have fun.
bye-bye.
Sometime though, I don't know. I'd like to talk about it.
Yeah, all right. Let me know if I find the name of a good astrologer.
What people do is just go right and kill them every time.
Strip.
Hey, you can just take a shirt off.
I don't, they didn't bring in this.
Would you put that in your purse? Just remember to take it out when we get home. Are you rolling?
Yeah, is that all right?
Yeah, that's fine with me. Sure is a quiet candle.
No deers, no lambs, no pigs.
You see my scar?
Wow, it's quite a scar.
Well, actually, it goes down further too. The first piece of surgery was just in through here. And they extended it down to the second one over and through here. And the discoloration you see is from the radiation. Same thing here.
Will the discoloration go away, or?
Eventually, yeah.
Yeah.
So it's,
And then a real coincidental thing happened at Thursday night, he got a real high fever, 103. Yeah, and all night. And I was up and called Tom to always ask for him. I was okay.
you talking about last week?
Yeah, and then Friday,
We can-
no
we can
pain,
go
out
back
of
in
pain,
there.
suddenly started feeling wonderful. And Friday and Saturday, after pain. It was incredible.
So, tell me all about it. I haven't seen you in a long time.
Yeah, this stuff with the methadone and the trazodone
Mhm.
really seem to have clicked in now, and I don't have any pain,
Period?
period. I don't have any pain.
How much are you having to take now?
100 milligrams a day of methadone and 150 of trazodone.
You take the trazodone all at night before you go to bed?
I have been, yeah, because
Uh-huh.
taking one in the afternoon, I tried that for a few days, and in the afternoon, I would just get really, really wiped, and I didn't like the feeling.
Mm-hmm.
So I just said, then hold it, I'll take all 150 at night before I go to bed.
How are you splitting up the methadone?
Seven pills in the morning, 6 in the afternoon, and 7 at night.
Have you seen Dr. Goldberg since that first time?
Yes, I've seen him again, and then I see him this Friday as well.
Mm-hmm.
And,
What does he have to say?
well, he doesn't know yet that,
You haven't seen him since?
yeah, the last time I saw him, I was still having some pain, and he just,
That's
what
when
did
he
get?
upped it.
That's
He had
when he
been on
upped it,
100
that's
at
right.
the
Yeah.
Trazodone, that's when he upped it to 150, and he'd been on something like 70 of the...
75.
75 of the methadone, and Goldberg upped it
Yeah, we upped it to 100.
100.
And since we went to 150 trazodone and 100 methadone,
Took about 5 days
yeah,
for that.
yeah, and then boom,
And now, just nothing?
There's no
There's
pain.
no breakthrough
No.
periods or anything like that?
no, it hasn't been.
What about all the trouble you were having from it, or at least I thought you were having from it before, the constipation?
Oh,
just
yeah,
kinda
that's, in
feeling
fact, I'm
weird
there
and all of
now.
that?
Yeah, I'm there now. I haven't had a bowel movement since, when?
Last Friday night.
Last Friday night. And today it's really hitting me.
Have you been doing?
There's just that constipated feeling, and I'm getting nauseous. I took a Compazine, and I've taken some I've taken 3 stool softeners, nothing yet. 3 stool softeners since last night, or since yesterday.
No.
I took 1 this morning and 2 yesterday.
Oh.
And I took a laxative this afternoon before I came here. And if the laxative doesn't work, then I'll try an enema.
Yeah,
See
you
if I can
probably ought
get
to
it
just take
started.
the stool softeners every day, or twice a day.
Well, I tried that, and I would wind up with diarrhea. I tried that once, where I took, you know.
You might have to
my-
fool around with it, though, maybe like take it every other day or something
That's
like
what
that.
Janet was
yeah.
recommending too, and I think that's what I've got to do.
Because
Now, is
I
find out
don't
what
think
that-
you'll get much acute relief from them, you know, like to be
Yeah.
constipated and take them. They're not going to work like a laxative. You
Yeah.
have to work out some kind of schedule.
Yeah.
What about the other problems, though, as far as being alert and able to do things and?
My alertness has been affected, I know that.
Mhm.
And I attribute that to the methadone, just to the drugs. And I'll lapse into, you know, kind of a state of semi-consciousness almost. In
Mm.
fact, I can feel myself kind of I say hallucinating, I don't think it is, but you know, my mind just kind of drifts
Drifting
off,
off,
and
yeah.
I'll actually start to fall asleep. And that usually happens about early afternoon, and then about mid-evening, say somewhere between 6 and 7 or something like that.
Mhm.
And my mind, I know my mind doesn't function at 100% during those times, but at least I'm
It was
conscious.
real bad when he was taking that one trazodone in the middle of the day.
Yeah.
Mhm.
Greg
Yeah,
would
I
fall
would-
asleep in his food right after he
Yeah.
took it, so.
But you seem like you're all right with that, though. I mean, it's not bothering you in the
With
sense
what?
that to have the symptoms, just the fact of having the symptoms.
With the drugginess and all.
Right, yeah.
I'd rather live with that than live with that
Yeah.
pain.
Okay.
Yeah, I can deal with the druggy feeling,
Mhm.
lightheaded feeling, and all that. The pain was just getting too bad.
Mhm.
Just living with it every damn day was just getting to be a real drag.
Yeah.
But so that's definitely under control, and it clicked in last Wednesday.
Friday.
Yeah,
And
somewhere.
And since then, that's been it, huh?
That's been it. Yeah, and that was I'd been on the methadone and trazodone for 2-3 weeks? About 2 weeks, I guess.
Since you'd first seen Goldberg in 3
Yeah.
weeks.
Yeah.
Yeah.
Yeah, but we had just upped it about a week ago.
Yeah.
Yeah. Before, a week prior to it.
So
Went through the
tell
pain
me
just
about the
abating.
trip.
Well, the trip was great.
Yeah.
That was fantastic. Yeah, we just
When did you get back?
just Saturday night.
Saturday night?
Yeah.
You were gone for a week?
Yeah, Saturday to Saturday. And it was just your usual sun and surf and,
Yeah.
and riding horses and
Had you ever been there before?
yeah, this was our second time.
Yeah.
Yeah, we enjoyed going back. And good food, and in fact, the hotel we stayed at, the Jamaica Hilton, was they've done some different things,
Mhm.
buffets, you know, and stuff like
Yeah.
that, and made it given it more of a Jamaican flavor.
Mhm.
And so the food was terrific, and shopping in Ocho Rios, which is a major tourist town now, and I said the horseback riding, and we went up Dunn's River Falls and had a lovely day rafting down a river.
Yeah,
Yeah,
that
that was the
sounds
day I had
good.
the fever too, coincidentally. Yeah,
Mm.
yeah. So that was, and you know, it's just really nice to get, and there was not a care in the world. You didn't have to worry about
Yeah.
anything. Just super, and the weather was just fantastic the whole time we were there. It turned bad the day we left. It was getting cloudy and overcast and was threatening rain.
That's the way to do it.
That's the way to do it.
Yeah.
Yeah.
He was really eating a lot too. I was really hoping he might gain some weight. Just kept feeding him, and I gained
put
4
on
pounds
pound.
for him. Why don't you think he's gaining any weight?
Well, before you really weren't eating that well, though. I wasn't really surprised before that you weren't gaining weight because you weren't eating very well.
Yeah.
I would see no reason, you know, if your appetite has come back, and I would imagine if anything, if it's, you know, going to stay, it's come back because the pain's gone and you don't have that constant, you know, distraction of being in pain. I would expect that you'd put on weight.
Oh, I hope so.
What did you used to weigh before you got sick? 140, something like that?
135.
135. I would imagine you know, I don't know if you get all the way back, but I would imagine you'll start to gain
I
weight.
think it's just going to take time. We've got to start on the milkshakes or something. Got to do something like that. But you see, that I'm so paranoid now about the constipation and,
Well, I
you
think
know,
that's the kind of thing that you're gonna have to, you know, like we talked about before, is realize that that is just an accompaniment of taking the methadone. And you, rather than wait until it's a big problem, you just kind of have to deal with it on a day-to-day basis. And like I say, I'd work out a schedule for the stool softeners either every other day or whatever. You may need every day now that you're on a higher dose of methadone. And I would stay on top of it with the laxatives. I don't think I'd let more than 3 days go by, and then I'd start with the laxatives.
okay. What about an enema? Should I take an
If the
enema?
laxatives don't work, yeah. I'd give the laxatives a chance. If they don't work, I wouldn't have any hesitation.
But right now, should I go home and take an enema?
Yeah, I
tonight?
think we're probably, you know, you're uncomfortable and so forth, and I would just go ahead and try to get cleaned out with the enema and then, you know, start from there.
Yeah, okay. This will work on tonight, getting relief. So anyway, when you're poking and prodding today, don't squeeze too hard.
Do you have to go back to Rhode Island anymore?
Do I have to go back to?
Yeah,
Rhode
did they
Island?
give you any kind of a?
Oh, Rhode Island
Yeah,
Hospital,
Yeah,
oh.
how are things,
Nothing going on there, no. Liftman doesn't want to see me, you know, unless there's something surgical, and you already know what his feelings are about doing
Yeah.
any more surgery.
and as far as radiation, when
Radiation
they
is
sort of
complete.
discharged you, they said, you know, the course is finished and you don't have to
That's
go
it for
back. Is
now,
that
yeah.
right? Okay.
I think everyone is just waiting to hear from you, if, for anything in the future. You know, if you want more radiation done,
Mhm.
or if you want Liftman to get involved, we want to take a look at some surgical procedure if we feel there's a need for one in the future. There.
Well, let me take a look and see. That's just good.
I don't know what to think about that back pain. I think.
Oh, that's right, I remember you
Yeah.
were telling me that before, yeah.
I just don't know what to make of it. Like, right now, I don't have any.
Well, that's great.
So it comes and goes, you know. I think it was probably just something, I pulled a muscle or something, and it's just taking its own sweet time and
We read an article the other day that said, on back pain, and it's so common, people over 35 or whatever. And it said that one of the statements made was that back pain often is associated with other problems, diseases of, and it named the colon, and the stomach. Is that true? Symptoms?
Yeah,
I mean, have you ever had people that have
I
backaches?
can't, I
with-
can't say I consider that
Yeah.
a strong association.
You gotta realize, we read this in Pan Am.
No, I think it was McCall, yeah.
I wouldn't be surprised if just from the fact that you've had so many things done internally, that you could have pain, that would, you know, be referred as back pain. That
I
wouldn't
just don't
surprise
put
me.
much stock in it, or,
Yeah.
you know, I'm not too concerned
Yeah.
about it, except that it's.
I think what you're saying is more likely, because it kind of started when you were doing that,
Yeah.
you know, you went from no activity to chopping the wood and all that kind of business. And
Yeah.
I think what you said before is probably the most likely thing.
Yeah, so it, you know, right at this moment, it's fine, and we just, you know, put Bengay on it, or, I think it's important that I just get on just start doing some exercises.
Well, I think that's right, yeah.
And I think that's one of the things about Jamaica that really helped, was that
It's probably why you had a good appetite.
I did a lot
You
of
were doing
walking,
things,
yeah, did a lot of walking, is getting a lot of
Just
fresh
gotta
air.
start slow,
exercising,
you know, and
yeah.
build up.
Yeah. So I bought a walking stick now. I have a reason to walk. Take walks.
Scares the dog to death.
Just, there you go, that's such a good one.
Oh, I guess I'll come back tomorrow for the blood work.
Yeah, I don't know what's the trouble down there. I don't really, I mean, you and other people have been here before and had blood on later on this. I don't know what the problem is, but.
I think the team goes up and does rounds. They don't have a night.
Well, that's
team
true,
anymore.
yeah, since that's recently, that's a change that's recently happened. Deep breaths. Good. It's not painful, huh? Or is it
No.
on the side?
In fact, when Janet rubs it, it actually feels better.
Okay, why don't we have you lie down? get much of a burn when they did that?
Yeah.
Is it even tender anymore?
It's tender now, but it's because I'm constipated, but
Mhm.
otherwise, you can do some poking around and I'll tell you.
Before, it used to be, at least for a
Real,
while there,
yeah.
toward, right before you went, it was tender just a little touch.
Yeah. My tongue, by the way, it's gonna sound, the last couple of days has had a burning sensation.
What's that? You didn't drink something wrong, huh?
I don't think so.
That's all right.
See right in there.
Here?
Yeah.
Well, maybe that's right on the suture, and I can feel those stitches in there, which I'm sure you can too when you put it in. Tender there? This side? No?
Slight.
Mm-hmm.
No.
There's a spot. On the surface, or do I have to press?
Surface.
Okay. All right. Okay. Yeah.
Why is that so tender? That has been tender right along.
I really don't know, you know, I can understand why, like, right here, I'm not surprised that when that would be tender, and I think that that's more the sutures than anything. But here, I know, that's the spot that it's been tender like that. It's soft, it's not like that, you know. It's anything to go from the side. It may be the graft pulling there. No tenderness over the graft.
No, it's as hard as a rock.
Yeah, yeah. No, I don't know, everything feels okay.
If there's another tumor, would that be where it's at? Right in there?
Well, it's hard to say, you know, it could be, you know, well, what I'm saying is if there were one, it could be anywhere. There's no way you could say that it would be more likely one spot or another. In the sense that you might think would be least likely to be there because that's been the area that's been radiated, yeah. All right. Want to get dressed?
Yeah.
What? Barbara Karen and Virginia came.
Yes, excuse me.
Time now to talk with Mike. If you have anything you wanna bring up.
This stuff from Fleet National Bank, that's gotta go to Confederation Life Insurance Company, which will run that way. Be making my payments. And the word here is expedite.
Okay.
I'm no longer on payroll.
Okay.
And, the insurance company is gonna make the payments directly to me. And it is financially critical. What I'd like to be able to do is pick it up from you tomorrow.
Oh, okay.
All right, and in fact,
If
this
you-
is the form I filled out, all right? My portion of it.
I can do it right now if you want.
That'd be great.
Doesn't
Terrific,
Doesn't look
okay.
too complex.
Yeah, I looked it over, it doesn't look complicated at all.
I'll tell you what, I'm gonna let you fill in the top, the name, address, and everything.
Okay.
So you need to be sure that we're saying on this side.
Yeah,
That's what-
the most critical thing, I think, is this thing about
That's right,
date
that's-
last reported for work. There have been 2 incidences that I can recall. That way I can carry it right over there. Hand carry.
Now, you know what's...
You know what?
We'll go ahead.
Yeah, why don't you go ahead and keep this?
Okay, all
All
right,
right.
you wanna come,
And
well,
fill it
you're
out.
gonna come back and have the blood drawn anyway.
I'm gonna have, I gotta come back tomorrow
Well,
anyway.
Let me ask you one thing, because sometimes there are tricky things in here.
Mhm.
They wanna know when the date when symptoms first appeared.
Mm-hmm.
I think that the best date to put down there is the day you were operated, or, you know, when you entered Rhode Island Hospital. Okay?
What time? Which one?
The very first time.
Okay, that would be back in February.
Yeah. The reason why I say that is because I know you were having different problems for a few years beforehand,
Mhm.
but I have a feeling if you put that, they're gonna say that you had this before you started there, and maybe there's some.
Well,
trouble
that's
about it.
before he started
That's
there
before I
anyway.
started there anyway.
Oh, is it?
Yeah.
Yeah.
Oh, well, I guess there's no way around that,
Yeah,
then. When did you start?
In
April.
That's when it was, right? Because you didn't start till after you had the operation?
Right.
Right.
Okay, well, I guess there's no, well.
Yeah,
I
the
guess
first
there's
piece
no
of surgery.
problem there.
Yeah.
Let's see if there's anything else. There's one thing, so the critical thing is when you last worked.
Yeah, what I wrote here, and I got this from my own personnel office, I put down 2 incidences. Last day, August 2nd, 1982. That was for, and then I returned to work on January 10th, 83, and then last day, February 23rd, 1983.
Okay, now the things that you probably need to be aware of that could have other implications. Okay, I'll put disabled for any other work, yes, right?
Mhm.
Okay, I'm just really sure that's what you're...
Yeah, that's usually the type of work that you're doing anyway.
Okay, and for this I'll put no. Okay.
Mm-hmm.
In this I'll put no. Is that what you want?
Mm-hmm.
Okay. In this, no.
Wait a minute. Right.
Okay.
Because it's just implications of.
Yeah.
I mean, you could always still change your mind. They're not gonna give you any trouble if you change your mind, but I just want you to know what
Okay.
I'll be putting down.
Okay.
All
Yeah.
right, so you wanna come pick this up from
I'll just pick it
tomorrow?
up from you, yeah.
The best thing to do is Kathy will probably have it.
Okay.
It's over in the Department of Medicine.
Yeah, because I've got to take that to him and a bunch of other documents as well.
I was just thinking, is there a problem with, the fact, that's interesting that you just said that. The symptoms
Well,
being there before he was.
I don't think it would be a problem in the sense that obviously they had your, see, in a way, you're much better off there because they knew what your history was and the diagnosis was made then, so they hired you knowing what your history was.
No, they didn't.
They didn't ask.
They didn't ask.
Well, but
There
at
was no
least there was
information
no,
sought
I
there.
mean, it was something that was available, whereas sometimes they might say,
Well,
well.
they knew that I had had the surgery.
Yeah.
They knew that he had surgery,
Mm.
but he didn't tell them what it was for, and they didn't ask.
But they didn't ask.
Mm-mm.
Well, I don't think anything, I'm not trying to make it sound like there is anything to be concerned about. It's
No.
just that, the main thing is that we're all saying the same thing. That's the most important.
Yeah, and that's my
thing.
concern
Yeah.
too, is if you put down a date
Yeah.
that is different than my date, then that just holds up the processing.
I've never seen anybody have any trouble with it before. I don't want to make you feel like that, that you're likely to have any problems. But I just like you to be sure that,
Yeah. My concern is just to make sure that there's no conflict information that has to be
That's
kicked
right.
back and
That-
has to be
that's
clarified and
most
just delays the processing of the whole thing.
Okay.
Okay.
What can I tell you?
Nothing, I guess. I wrote something down here. No, I don't want to discuss it.
All right.
No, it's just about the prognosis. We beat that thing into the ground. I'm on disability because of the last discussion we had where
Yeah.
that question I asked you, and you said how much, 24 months, 36 months and all that.
Yeah,
that's-
I think all that they are going to want to say, want to hear is that, is there, a chance of recovery from your current disabled state? And I think I have to put no.
That's essentially what I said. The prognosis is that the disease is terminal. Not that I'm terminal, but the disease
right.
is terminal.
It's not any kind of a damning thing in the sense that, should the day come when you feel like, I want to try to do this again and try to go back to work, they're not going to say, oh, no, we have this written down, you can't do it. So.
Yeah. Well, in fact, my employer's already said anyway, or my boss has said that, if I ever want to come back to work, this decision is not irreversible.
Yeah.
So.
Mm.
Mm.
Are you going to plan another CAT scan?
Oh, good. Yeah. Good.
Well, I'll tell you the way that I feel about it. Right now, we want to get the blood tomorrow. Assuming that the blood tests are normal, which my guess is that they're going to be. I don't have any big desire to do a CAT scan right now.
Okay.
You feel good. I think that from what we have talked about and, gone through in the past, and which you have the personal experience of, is you know now that when you're feeling good, you don't want any therapy. Unless you've changed your mind from when the last time we talked about that. Then, if we do a CAT scan and find that the questionable masses are masses, or that the questionable masses are masses, and now instead of being 2 centimeters, they're 3 centimeters, we're not really going to do anything different anyway, right?
When would you?
Yeah.
Well, my feeling
Forgotten
is,
about those
based
things.
on what, we've said before, is that I would do something when you started to have symptoms.
Symptoms meaning pain?
Anything.
With the amount of methadone and trazodone that I'm on now, there's a strong likelihood anyway that I will not experience any pain.
I don't think that that'll be the case. I think if something new comes up, you will know it, because it'll be a difference, it'll be a change.
Like what? If you do you mean pain or not pain?
Pain's a possibility.
What's
It
other
has
possibilities?
Problems with your bowels in the sense of maybe having diarrhea, or maybe nausea and vomiting, or that, there's a number of problems that could come up. So it's hard to predict. See, my only point is that if you're feeling, I've gathered from what you said is that what you are going to use as your guide is the way you feel. And I'm one thing that I'm confident of, and I think you probably are too, is that we're not going to get in any more of a definitive explanation or etiology of what the pain is that requires methadone. I just don't think that we're going to have. I don't think we're going to come up with some concrete explanation. It was because of this nerve here, or whatever. I don't think we're ever going to get that. And I don't think it matters whether we get it or not. Personally,
The point is that I'm pain-free for the first time
that's
in a
right.
long time.
You feel good, and I don't think there's anything different we could do about that to make you feel any better. And so I don't see any point in trying to do something different.
Okay, but my concern is, as I recall, there were three abnormalities. The
Right.
abdomen that we've radiated, but then there was the
Questionable
pancreas, yeah.
abnormalities,
There was the pancreas and the rectal area.
Right.
I don't want those to get out of hand. I suppose what I'm saying is that if there has been a change in those areas, I want to know about it as soon as possible,
Well-
because wouldn't
It depends on what
the
you
rate
mean.
of growth or whatever affect?
It depends on what you mean by out of hand.
I would want to catch it as early as possible so that we could treat it, I suppose is what I'm saying.
Well, and that's a different thing, say. So in other words, what you're saying is if that's confirmed by one way or another to be tumor, then you will want treatment.
I would
even though you're
want
asymptomatic.
I would want to have to make that decision, let me put it that way. I would want
Okay,
that
well,
option.
That's a different issue.
Yeah.
All right, then that's a different issue. Then I think we can pick a time and say, we'll do the CAT scan at that point. It's, well...
You know, I just want to
Doing CAT scans
know.
at
I
that
just want to
big
know
a
what's going on with
Yeah,
my body.
okay, well, that's understandable. I was, perhaps I misinterpreted the way you wanted to approach it, because I thought you were going to take the tact of, I feel
If I
good,
fe-
then I don't want to do
And
anything.
that may be.
Yeah.
You may come back and say, hey, the things have doubled in
Yeah.
size, and I'll say, oh, well, I feel good, I don't want to do anything. Or I might say, well, let's let it go for a couple more months. I don't know what I would
That's
say,
fine. Sure,
but
okay.
I at least want to have the
No,
option, the
I can
choice of saying
understand
it.
that. I think that's fine. Well, let's see when you have it.
Because if the one thing about it, if you were able to confirm, let's say, if they turn out to be tumor,
Mhm.
and due to a certain size, would you be able to somewhat predict what kind of complications they might cause? If, for instance, if it were a
Well-
tumor in the pancreas, what kind of things might happen?
I don't think that the predictions would be any more valid than just guessing, because tumor in any of those spots could cause a variety of problems. So I wouldn't be too, if a problem, I don't think you need to worry about something happening that's significant, that's so subtle that you don't know if it's a problem. If something happens that's a problem, you're going to know it, we're going to know it. I don't think you need to be sort of concerned on a day-to-day basis that, gee, is something going on, and, we're missing it, either the methadone is masking it, or, for some
Yeah.
reason. If it's a real problem, then it's gonna manifest itself.
But there's not a matter of it being a real problem and you starting the treatment then as opposed to treating it right before it was a real problem.
I don't think so.
No, not a difference. Okay.
Like we've talked about before, the treatment just isn't that good.
Now, that's true of wherever this particular kind of cancer is. I mean, we know that it's that same kind of cancer everywhere, is the point.
Right.
Okay.
Because, like we talked about before, if the treatment was that good, I would have given you a bad time when you wanted to stop before.
Yeah.
Well, and nothing's been happening in the field in the last year, huh?
Well, I'll tell you, a lot of things have been happening, but nothing that's at a definitive stage where I can say, yeah, that we have something new
That we can
proven to
try.
offer that we didn't have before. A lot of things have happened, but nothing that has been either exciting enough or evaluated extensively enough to,
Yeah,
change our
I'm not in the mood to be a
plan.
guinea pig either.
No,
Well,
but
let's-
if we get to that point, do you have some stuff that
Oh,
you
yeah.
would be
The
willing to
things-
experience around
The things
with?
that Dr. Calabrese talked about last year, I guess it's almost a year, those things have been undergoing evaluation, and now things that he was just talking about, perhaps soon we could use, well, now they're in use and we're gaining experience with them, and but there hasn't been enough done to say whether they're really going to be useful, but yes, there's a variety of things we can do.
Okay. Because I just want to hear this, because I guess one thing I've gotten kind of let myself get down with the thought of, whenever the cysts come back, all you're going to try is that same old 5-FU and hydroxyurea till the very end, and that's
No.
a depressing thought, because we know that doesn't work, or that's not
No.
very good.
Well,
Not work, but
I don't know that we
that
ever,
promising.
that we definitely showed that, but,
I don't like it.
Well, the others may not be any more pleasant.
You had the last one.
It was in January,
In
first part of
beginning of
January.
January, February. I would think that it wouldn't be worthwhile to do it until 3 months have gone by, so we could do it sometime in April, which means we probably will have to go ahead and book it now, because there'll be a wait.
That sounds good.
Sounds bueno. to
Gives
me.
us a month of good time before we
Yeah.
But see, that,
may
to me,
learn something.
but see, to me, in a way, that's the, well, it's a personal type of decision, but to me, that's the danger of all the testing, because then you get hung up on the test.
That's true. That's true. In fact, we're hung up on it, not even having them, constantly talking about when will the next one be. We're so hung up on them. That's true.
Well, it's not like there's a right way and a wrong way. You have to do the way that you're most comfortable with.
There is that point, though. I mean,
See, to me, I'll just tell you
Ignorance
from
is
my own,
bliss.
well, I'll just tell you from my own perspective, is that another approach, which is kind of what I thought you wanted to do, but is that if basically, if the goal is to be comfortable and to feel good, then to do the test and to pick the disease up at some earlier stage when your choices will be, okay, it's not, we know it's there, but I'm not having any symptoms from it, so I can make the choice of taking treatments which are bound to have some side effects, or continue on with no treatment until I do start to have some problems from the tumor, in which case then the side effects of the treatment might be might be worthwhile, or, worth taking the treatment because I'm having some problems that I'm fighting against.
Then you just sit there waiting for those symptoms to happen, once you know it's there.
he's got a point.
But, my only point is that, if you do the CAT scan, well, you have a 2-centimeter tumor, and then you do it in 3 months, and you have a 4-centimeter tumor, and if you're feeling good. I'm not trying to tell you what to do, because I think,
No, it's
obviously
fine.
would.
It's a good point.
Part-
Because I already know I won't go through that chemotherapy. I won't go through
Until you have
the
symptoms.
5-FU and the hydroxyurea until it's really bad.
Well, obviously, a large part of feeling good is peace of mind, so you have
Yeah.
to also do the things that you think are going to give you the most peace of mind, and if you feel like having the test is, could perhaps give you peace of mind, then,
Let me think
I
about
think
it,
it's
okay?
reasonable to schedule.
Let me think about it.
Well, we can go ahead and schedule it, and we can always cancel it if you want to. So, however you want. But I think it's just what's gonna give you the most peace of mind. I mean, obviously.
Okay,
we
go
just
ahead and
do-
schedule, and you and I can talk about it, because that's a very good point.
We just
and-
can't do them willy-nilly,
Yeah.
but, you know, I think it's reasonable, a 3-month period to take a look, and if you feel like that, well, given new information, you know, perhaps I'll have a different decision, that's extremely reasonable to
Yeah.
do it. But if, on the other hand, deep down, you know, no matter what it shows, I'm not taking any treatments, or I
Yeah,
feel
see, that's,
good,
that's,
then why even have that weighing on your mind, gee, now it's big.
and you know that's kind of the way I feel too, because it's, there isn't much we can do to cure this
Well,
tumor.
like I say, it's, you have to kind of think of what's gonna give you the greatest peace of mind. Obviously, it's kind of like, in a sense, a dice shoot, because what you would like is to have it and then it be normal, and then you have peace of mind.
And if you get it, then you have even
But if you get
less.
it, but then if you get it, you know, you have to be ready to deal with a bad result as well as a good result.
Mm.
Well.
Something to think about,
We can
yeah.
schedule it, I'm sure it'll take at least a month. You know, if we schedule it today, I'd be surprised if we get it any sooner than a month anyways. We can always cancel.
Okay. Oh, the fatalist in me, the melodramatic me always, you know, wants to know.
Well, some people feel better now, you know, like I say, it's highly individualistic.
Well, I'm an ignorance is bliss person.
Go ahead and schedule it.
Realist.
Don't be surprised if I decide to cancel it.
Okay.
Okay. Anything else?
That, no.
Okay.
But right now, how do you feel?
Good, good. You feel good, you look good?
Would you say I'm in remission?
We just don't.
What the hell is remission?
Yeah, and this, you're right, in this disease, I don't really know how we would define that, but, say we're in a state of uncertainty because we just don't know what the best piece of data that we have is the last CAT scan, and even that is so vague that we just can't say.
Oh, you get the pessimist Liftman.
Yeah.
It's a nice balance.
Hmm.
When do you want to see me again?
6 weeks.
Okay.
God. So you think you'll feel good for 6 weeks?
Well, if I'm not, I can always come in.
call up, yeah.
Well, that's encouraging. That was an optimistic thing to say. 6
Hmm.
weeks. As long as you've ever gone.
Mhm.
Well, you know, again, I think the important thing is to pick a goal and then, you know, we'll be consistent. I think right now, the goal is to go along, feeling good, and deal with problems as they arise. And, you know, I think we'll be consistent in the way, you know, not totally close our eyes to the situation. I mean, do the simple things, do the blood work, examine, things like that.
Okay. Anything else? Let's hit the trail, partner.
Okay.
And then you're gonna come back tomorrow and have a...
I'll come back, yeah, I'll
Oh, that's
stop
right.
off with, I'll go to your secretary over in the department there, Kathy. Pick that up tomorrow, okay?
All right.
Thanks.
Be sure you have all your cards.
Yeah, email for the blood work?
I just tripped on
The blood work?
Yeah.
Yeah, I've got
Maybe we'll go ahead and give you those for next time too. I don't know if you may want to do that if that one is still here.
We'll schedule Tuesday night we've got, and we'll schedule something at the house.
Okay. Is,
Good.
yeah, what time am I gonna see Drew on Tuesday night?
6 o'clock.
6 at the
You
athletic
know,
club.
between 6 and 6:15.
Okay.
Faculty club, not
Faculty club.
athletic club. None of these guys are too athletic.
Faculty.
Faculty club.
Do you know where, you still have those directions?
I got the map, yeah.
Great.
With some time out at the house too, just to come out and do shooting,
That's great.
change a
I'll be all the
tire,
time.
chop some wood.
Chop wood?
I don't know. No.
Well, she's not even here anymore, so we'll just deal with it all tomorrow. I guess
Okay.
we'll schedule a scan and give you the other cards. You know, if there's any problems, obviously, call up.
Good. Thank you.
Okay.
See you in a while.
All right. Just, you know,
go ahead and make the appointment with the secretary like usual, and then tomorrow we'll give you the rest of the...
Oh, in a long time anyway, probably the very first time.
Yeah. He seemed pretty sure about, just where he was and sort of making plans.
Yeah, he's finally decided what he wanted to do, which I think was something that was giving him a lot of problems before, particularly about not going back to work.
Yeah.
Because I think he really wanted to stop working a long time ago, but was having a hard time coming to that.
Because stopping working meant that he wasn't
Well, I
able.
not, I don't know, that I guess, yeah, I guess so, and just the fact that that's what you're supposed to do,
Mhm.
go to work.
Yeah.
And a lot of it too is the fact that he's had a lot of problems with pain, but he hasn't had, any of the major things happen. He hasn't,
Mhm.
well, I think he just was having a hard time coming to the, getting it okay in his mind, that it was okay to stop working.
Yeah. Pain without symptoms?
Yeah, without overt problems that other people could easily recognize.
Uh-huh. Yeah, that seems to be a big problem, question, this whole thing. Raises all kinds of other questions.
Yeah.
Believability and so on. What did you think of the conversation you had with him about am I terminal and so on and so forth?
Oh, yeah, well, that's, we've had that conversation many times. In fact, I'm surprised that, in a way, I'm surprised he didn't get into it more. And in fact, if anything, that was sort of a break of the usual pattern, because usually he would, we've been over that many times, but this is the first time when it came up and he didn't want to really pursue it in great depth and say all the same things all over again. He was willing to just, well, we've talked about that before.
Uh-huh.
He looked good to me, he really, not only physically, but he just seemed.
Mm-hmm. Would you say that he's a patient in your experience who has fully accepted the fact that he really is going to die?
No, in fact, to me, if anything, I think this kind of indicates to me that he's still, that if anything more than ever, it's sort of an unbelievable thing, because like he was just saying, he's making plans now, and he has these sort of long-range plans. And that's the first time he's ever really done that. He's really put things in order. He's made decisions. He's not going to work. He's going to do these other things. And I don't think he's counting on the life that he's laid out for himself now coming to an end anytime soon. I mean, I don't think really deep down he accepts that.
Right. So in other words, he probably holds out some hope on some level that when the symptoms do recur, when the tumor does recur, you can do something about it.
Yeah, I think so. Or that it's just not going to recur again.
What's the likelihood of that happening?
It's very, very small. The odds are overwhelming that he will have disease and recur, and that it will happen soon. It's been almost a year since his operation. He's really done well from that standpoint.
Hi. Come on in.
Are you finished?
Almost, but...
Yeah.
Okay.
You going upstairs?
I've been upstairs. Everything's under control.
Those people that were admitted, they were your people? I mean, people that you knew?
Only one.
Oh, the Quigley
Yeah,
didn't come in?
Mr. Quigley's not coming in.
Okay.
Okay. So,
So that person's...
everything's under control.
Was it
and
that lady with ovarian?
Yeah, she's all tucked in.
Okay.
Okay, I'll see you tomorrow.
All right, good.
Bye. Thanks.
Okay. How typical is he? How typical was that exchange that you just had? I mean, how often do you have that kind of exchange with patients?
He talks about things more than most patients.
He does?
Yeah, he's not a typical patient. Most patients don't want to get into these discussions of such detailed discussions of prognosis and likelihood of specific things happening to them. He's unusual. Well, he's unusual in that regard from the majority of patients, but then just the very fact that he's a young person makes him unusual. And probably if you took that subset of patients that we have that are young and young and intelligent, he probably is not too different from that group, I guess.
Mhm. Do you feel in general happier when you've had a discussion like that with a patient, or?
Oh, yeah, I'd much rather deal
Mhm.
on that level. Although, in a sense, it makes it easier on the physician, because then you can make them aware of everything, and you don't. It sort of gets the burden off of you in a way, because they know everything that you know, and particularly people like this that are very intelligent, and they can ask very pointed medical, anatomical type questions, and you can give very specific and sort of answers in medical terms, and they understand that, and there's no problem. So it's easier in that respect, but in a sense that most patients, after you've spent some time with them, you know what level of understanding they want to operate on. And really that's the important thing, is once you figure that out, then it doesn't really matter that much or how little they want to know, as long as you have this understanding that you know what they want to know.
Have you actually had the experience of telling a patient that they were going to die? A patient has turned to you and said, "Doctor, am I going to die?"
Oh, yeah.
In what kind of circumstances does that usually happen?
Very frequently, just like, circumstances just like today, seeing them as an outpatient. We had a patient upstairs now, a lady with leukemia, who, sort of similar in that respect, and asked very pointedly, how many weeks am I going to live? If I take this treatment, what will happen if I don't take treatment? Does that mean I'm going to die? And so forth.
Mm-hmm. How do you usually answer that question? Am I going to die?
Well, generally, if somebody asks that specifically, I answer specifically. I don't like to give prognoses in the terms of so many days, so many weeks, so many months, simply because I don't think it's very difficult to be accurate. But I think you can, people that very specifically ask for a range, well, you can't tell me, the exact time, but are you talking about weeks, months, or years? And I'll answer questions like that if the patient asks it in that context.
Mm-hmm.
Most patients don't do that, but patients that do, I'll give them the information.
Mm-hmm.
Like this lady, she's, she has a home in another state, and so she really wants to know because she wants to go take care of her business and so forth. So I feel like if people ask that question, I wouldn't tell that to somebody if they didn't specifically ask it, but if they ask.
Just another question about their relationship. The way in which they talk about his body as if they're, two heads on one body.
Yeah.
How typical do you find that, or is this been true all the way along and so on for a spouse to?
Yeah, I think that's pretty typical. In fact, both the patient and the spouse will, in a sense, take sort of a detached view and an objective view of what the physical condition of the body is, and even the patient will talk about his own body as sort of as third person, and it almost becomes an object that you have to. If we're a machine or something, you have to care for it, and well, he ate this, and today, and it's giving him gas and such, and they, I think that's kind of common to have this almost detached view, and I'd say you see that pretty frequently.
Does he involve his wife in intimate details of his own care more or less than most patients?
I think he talks more freely about it to her, which is a good thing. And of course, it's hard to know, because the thing that you see, or at least that I in my impression, is one of the biggest, I guess, tragedies, or the thing that makes situations like this hardest to deal with, is when what very frequently happens to people when they start to have very significant symptoms like pain or so forth, debilitating symptoms, is that they, of necessity, have to become so involved with themselves that they lose the ability to interact with their family, and even people that really love them and are trying to do everything for them, and that they know this, they understand this, but it's just such a fight for comfort, or just sort of maintaining yourself at a very basic level on a day-to-day. It takes all their energy.
and they can't interact with anybody, and then they lose the help on an emotional level that they could get from other people because after a while people they just feel so rejected that they can no longer be as supportive and so forth. The wife, after being told so many days in a row, just shut up and leave me alone, finally she's going to do that. She's going to shut up and leave him alone. And it's a problem that I there's no real answer that I've seen, because you can understand from the patient's standpoint, they're near death, they know it, they're having all this pain, it's such a struggle every day, and they just can't be bothered with anybody else. But yet, it very often costs them the emotional support that would make this time a little bit more bearable. But so the fact that he's able to tell her things and sort
Involve
of
her in
involve her,
progress.
and even if it he says something to her that'll make her mad, still the fact that they've been communicating all along, then they can I think get over it better, because she goes through a lot of things with him. But then on the other hand, I don't want to say he hasn't been that sick, but he hasn't had life-threatening type complications yet. So I don't know if that will change when those things set in.
One of the things that they have talked about on videotape is their relationship does get fragmented when either of them feel the caregiver, whether it's the nurse or the hospital or the doctor, gets in between them. And of course, the sicker he gets and the more unable she is to do what he needs to have done, the more inevitably it will be that other people will.
Well, like
play
when that period of time when he was coming in the hospital fairly frequently for pain control, there was at one time where he was in the accident room and she just did not want him to be admitted, and asked that we not admit him, and tried to talk him out of being admitted for that very reason.
Right.
Yeah.
And he's responded by being very responsive to a lot of the care that he gets in the hospital during that time when he really needed a very basic
that's
kind of
right,
care.
Yeah, because then he's getting emotional support from other people.
Right. Okay. Well, I think this was an excellent session for teaching. It was really excellent. And we could use this alone, I think, just in your interaction with them and so on for younger doctors. And when you were talking about the Jamaica Hilton, I thought, gee, why don't we get the Jamaica Hilton to sponsor this?
know. That's right.
Send us your cancer patients, we will.
That's right.
So, anyway, okay, Mike, thanks a lot. You've been very
Okay.
patient with us. We'll stop now.
What did you think?
Well, I thought it was fascinating. I mean, it was very interesting to being out there. I guess I could hear more of the ambivalence than I would have been able to if I'd been in the room with them. I don't think he has, intellectually or cognitively thought through the whole story. I keep asking myself, before I did this work, could I have? And I don't think you can. If you haven't been through it or even watched it, you can't imagine it in some ways.
See, to me, the thing that the issue that was very difficult that we were talking about today is basically it doesn't matter. It doesn't. But I don't want to come out and very specifically say that, because I think that would, I don't think.
Really abandoning him.
He would have a hard time with that.
Right.
She would have a very hard time with that.
Right.
So on the one hand, I don't want to come out and say it doesn't really matter what we do at this point. But also, I don't want to give him the feeling that there's some reason why he has to keep going through all this.
Yeah.
Because there really isn't. If it doesn't matter when we find these things, we'll find them, and there's not much that can be done about it. And he's already shown that his tolerance for therapy is so poor that I wouldn't want him to ask me to be treated at a time when he was asymptomatic. Obviously, if he did, I'd have to tell him what we have to offer. And, if he said, well, I want to try this, try it. But I hope it doesn't come to that.
Yeah.
I hope he doesn't want to be treated anymore until he has a symptom. And then there'll be a trade-off. Then we'll be trying to accomplish a very specific thing.
Yeah. I guess you then can think about what role is the hope that there is something playing. In fact, he probably has even indicated, deep down I'm not going to take that. I think I heard him say that sentence. But it may be that symbolically he needs to keep you in the position of somebody who has something to offer because he wants to retain a relationship.
Yeah.
And
Well, plus I think, too, is that they would really like to have the test because they really want it to be negative.
Yeah.
And they really want that so bad that but
I that
do
was
the
a-
test.
You have to live with the results.
Yeah.
No, I thought the way you reflected that reality to him was marvelous, because you know, you could. That's exactly the reality. He could get all involved with making the appointment and setting it up, but you took
Mhm.
them the next step, which is that the results are going to come back, and they could go either way.
Yeah.
And given a choice, he could maybe at this point can back down and not face that moment.
It's like we have patients like with Hodgkin's disease, young people, you know, same sort of thing. They've never been sick, they can't deal with it, the treatment's terrible, and so forth and so on. And we really have to twist their arms every time, you know, just do everything we can to force them to continue to be treated, because it can really do them some good. But it's just such a different situation, and it was sort of like in the beginning there was a one-shot thing. It was essentially he was free of macroscopic disease, and we were going to try to give him some chemotherapy in a quasi-adjuvant type of setting. But once he relapsed on that, it was really, that told the story right there. And I just hate to see him keep subjecting himself to all these tests, and then not only for whatever discomfort the tests are, but just for the fact of then you got to be so worried about, you know, well, this time it showed this, and now it's
Right.
it's a little bigger, and that's terrible.
That's right.
And
Get off of that treadmill. No,
Yeah.
that was good. Okay, Dennis, you want-